Hello, my name is Ivar Eide. I am a consultant doctor at Akershus University Hospital. We have made 4 information videos on Covid-19 tailored for persons with chronic kidney disease, transplant recipients and other persons on immunosuppressive medication. And it is this latter group that is the target for this video. I will also talk about coronavirus vaccines, which should interest everyone at the moment. I recommend that you watch the background information video first, followed by the video tailored for chronic kidney disease before you watch this video. Persons who have received a kidney transplant from a family member, relative or friend are often concerned that this might negatively affect the life of the donor. During the corona pandemic, many recipients are worried that the kidney donor lacking one kidney might be at increased risk of COVID-19. Fortunately, kidney donors who are infected with the coronavirus have the same outcome as the general population. The risk of serious illness during COVID-19 depends on age and gender, just like everyone else. And it depends on the function of their single kidney. If it functions well, there is no excess risk. This also applies to persons with a single kidney due to other causes, like the ones who had to remove a kidney due to cancer. Some potential donors are worried that they might infect the recipient with coronavirus when the kidney moves from them to the recipient. This will not happen. There is a test procedure prior to donation and only kidneys free of coronavirus will be donated. Kidney transplant recipients suffer a higher risk of serious or critical illness during COVID-19 due to the use of immunosuppressive medication and because they often have reduced kidney function and other diseases like diabetes or heart disease that increase the risk. Compared with people the same age and adjusted for other diseases, organ transplantation constitutes an increased risk of fatal outcome from COVID-19. To a large extent, this risk is due to the use of immunosuppressive medication, and as you can see from the diagram, use of immunosuppressive medication due to other diseases also increase the risk. Within the group organ transplant recipients, age is still the most important risk factors. This is important to acknowledge when you look at this figure to understand that it shows your excess risk compared with people your own age. So if you are 40 years old, your risk of fatal outcome during COVID-19 is very low, around 0.1%. If you are 40-year-old and a transplant recipient, your risk is 3 to 4 times higher, but still well beneath 0.5% and therefore still quite low. I hope this comes as a relief for many of our young transplant recipients. It is self-evident that medicines that lower either B or T lymphocyte responses makes it harder to combat infection. These medicines are, however, necessary to avoid recurrence of an immunological disease or organ transplant rejection. It is these lymphocytes and their signal mediators that set off the attack on the intruder during an infection and therefore produce the first symptoms. Fever might be the only symptoms, even during serious illness in persons receiving heavy immunosuppressive therapy. This is also the case with COVID-19. Although upper and lower airway symptoms often occur also in this patient group, fever and gastrointestinal upset are more common debut symptoms here than in the general population. You should therefore have a corona test if you experience these symptoms. You should also have a test if you think you might be infected even though you have no symptoms, because it might take a few days for symptoms to develop. And there might be very mild symptoms early on during COVID-19. Since the immune response from B and T lymphocytes is weaker due to the immunosuppressive medication, you might have a weaker and shorter duration of immune response if you catch the virus. Recent studies show that persons in the general population who undergo COVID-19 are protected against reinfection for many months. We are not sure about the magnitude and duration of the immune response in persons who use immunosuppressive drugs. It might be a bit shorter. You would expect that this might lead to more reinfections in organ transplant recipients, but this is not the case. Studies across Europe show that organ transplant recipients are less often infected by the coronavirus than the general population, and this is likely due to better adherence to disease protection measures in these patients and their household members. This is our impression in Norway as well, so you have done a great job so far. For those of you who already caught the virus, bad luck can happen to everyone. Unfortunately, it was your turn this time around. You should still protect yourself against the virus and take the vaccine because you might unfortunately suffer a reinfection. Some medication almost completely blocks B lymphocyte function, like rituximab that we told you about in the video tailored for chronic kidney disease. Other drugs primarily affect T lymphocyte function, and we will now take a look at them. It is important that you tell your doctor if you catch the virus, because it might affect your regular medication. Your doctor will manage all of the adjustments that has to be made, be sure of that, but we get a lot of questions about it, and it could be good for you to know why we need to change medication during COVID-19. Basiliximab is a powerful immunosuppressive drug that is given at the time of transplantation and blocks interleukin-2, which is necessary for T lymphocyte proliferation. We will still want to use this drug as normal. Other immunosuppressive medications like tacrolimus or cyclosporine, sold as Prograf, Alvagraf, Envarsus or Sanimune for instance, also affect T lymphocytes in a similar but milder manner via another route. This stops the T lymphocytes from launching a rejection attack on the transplant, but it also puts the person at risk of serious illness during COVID-19 during the first 3 months post-transplant. The ability to produce an effective vaccine immune response is also lower, and we recommend halting vaccination to 3 months after transplantation. Transplant recipients will receive information about this during their stay at the Rikshospitalet. Tacrolimus and cyclosporine may be used during COVID-19, but your doctor might reduce your dose a little bit, and you will have to take more blood samples to ensure appropriate drug concentrations. Prednisolone will be continued as before, or the dose will be increased. Mycophenolate, which is the active compound of drugs like Cellcept and Myfortic, will normally be lowered, or it could be temporarily removed during serious COVID-19. This medication may lower lymphocyte levels, as does serious COVID-19, so the combination of the two does not work well. Some organ transplant recipients use azathioprine, which is found in the drug Immorel, and dose adjustments may be necessary also here. Intensive care during COVID-19 for organ transplant recipients and other persons on immunosuppressive medication does not differ from other patients. It focuses on oxygen supply, ventilators and dialysis for those who need that. Prednisolone might be switched to dexamethasone, a more potent steroid. It seems reasonable that this group of patients might benefit extra from antiviral drugs or convalescent plasma, as discussed in a video tailored for chronic kidney disease. In that video, we also spoke about vaccine priority groups. Organ transplant recipients and persons who use immunosuppressive drugs due to other immunological diseases like glomerulonephritis or vasculitis and are under the age of 65 years old belong to vaccine group 4. Remember that the coronavirus vaccine does not infect people with the coronavirus, and that the vaccines that are offered in Norway are shown to be effective and safe in large clinical trials. We recommend that you take the vaccine. We recommend that your household members also take the vaccine. We recommend that every adult person that can be offered the vaccine takes the vaccine. Pregnant women should only receive vaccination if they belong to a high-risk group and only after consulting a doctor. Women who are breastfeeding may take the vaccine. When we talk about vaccines, we talk about vaccine platforms. This corresponds to various ways of making a vaccine. Here is an overview of these platforms and which vaccines that are currently emergency approved somewhere in the world, but not all of them are approved in Norway. Live attenuated vaccines should not be given to persons on immunosuppressive regimens, and coronavirus vaccines on this platform will most likely not be offered in Norway. Inactivated viruses are viruses grown in living organisms that are later killed to harvest whole but dead virus, which is still enough to set off an immune response. Influenza vaccines are made in this way. Numerous coronavirus vaccines are made on this platform, but they are less effective than most of the other vaccine platforms, and it is not certain that they will be offered in Norway. A new platform is RNA vaccines like Pfizer-BioNTech and Moderna vaccines. These vaccines are based on parts of the virus RNA, in this case the spike protein, and not the whole virus, because it is sufficient to produce antibodies against the spike protein to prevent the coronavirus from entering our cells. The coronavirus is an RNA virus, and DNA vaccine platforms are therefore redundant. Protein subunit vaccines contain small parts of a virus that trigger an immune response, or particles that are not in the actual virus but resemble them so much that it will set off an immune response. HPV and hepatitis B vaccines are examples of such vaccines. There are coronavirus vaccines on the way on this platform, but it is not clear whether they will ever come to Norway. On the other hand, we should expect that at least a couple of the virus vector vaccines will be approved in Norway. The virus that functions as a vector is a harmless virus, usually an adenovirus. Genes from the coronavirus are added to the adenovirus, and our immune system responds by making antibodies directed at the coronavirus and the vector virus. This platform was used for developing Ebola vaccines. Several coronavirus vaccines use this platform. In Norway, the AstraZeneca vaccine will be the first of these to be approved. Several coronavirus vaccines are developed already, and many more are in the pipeline. RNA vaccines are approved in Norway. So far we have received some Pfizer-BioNTech vaccines, but Moderna vaccines are also on their way. The Pfizer-BioNTech vaccine should be given with a 3-week interval and the Moderna vaccine with a 4-week interval. It is as yet not clear when we will receive the AstraZeneca vaccine. RNA vaccines show very promising results. The principle is that the RNA sequence that codes for the spike protein is identified, isolated, copied, and put into lipid nanoparticle droplets. These are injected into the body and set off an immune response. The spike protein alone cannot become a virus, so it will not infect us. The spike protein contains many sites where antibodies can bind. The mutant variant of concern coronavirus has changed 2 of these sites, but the vaccine should still be effective also against this variant. One of the mutations of the variant of concern makes it more contagious, and this mutation is found both in the British and South African variant. We do not know whether these variants emerged independent of each other. It is important to try to stop this variant from spreading across Norway and from getting a proper foothold here, like it has done in other European countries. If we should fail to stop the spread, it is fortunately possible to change the recipe for a future RNA vaccine to target it better at the variant of concern instead of the original virus. RNA vaccines are very effective. Large clinical trial has been undertaken where many thousand participants were divided into 2 equally sized groups, one that got the vaccine and one that did not. And then they compared number of COVID-19 cases in the 2 groups. Nearly all the cases belonged to the group that did not get the vaccine. Only 1 in 20 belonged to the group that got the vaccine. This adds up to 95% efficacy. Moreover, these vaccines showed a strong B lymphocyte response measured as antibody concentration in blood and a strong T lymphocyte response. In conclusion, they offer good protection against serious illness from COVID-19. Virus vector vaccines are less efficient, although 70% efficacy for the AstraZeneca vaccine is still quite good for a vaccine. It is common to get a local reaction where the vaccine was given in the first couple of days after vaccination. This reaction only means that the body is working to produce an immune response, and that is what we liked it to do. Mild temporary side effect that feels like a mild influenza infection is also common. Some may be very tired and have fever and might even stay in bed a couple of days after the second vaccine dose. This is not dangerous, but we recommend that you take the test for coronavirus to rule out that you did not caught the virus coincidentally at the same time you got the second vaccine dose. It is only a few weeks after the second vaccine dose that we are certain that the immune response is there. Since the vaccination studies did not include transplant recipients or persons with advanced kidney disease, we do not know how early the vaccine offers protection in these patients. Anaphylactic reactions, like the person in the middle here, is a rare adverse event that manifests itself within minutes after vaccine, and is the reason why we ask you to wait 20 minutes before you leave the vaccination center in case you need treatment. There are other very rare autoimmune adverse events like facial palsy, which usually recovers within weeks. These are very rare events, and it is paramount that you contact your doctor should you experience any unusual reactions following vaccination. We believe that the vaccines will be effective also for patients on immunosuppressive treatment, but we do not know how strong the immune response will be in these patients since they were excluded from the vaccination studies. Some may need a third vaccine dose, we simply do not know yet. We also do not know the duration of the immune response. There is also a theoretical concern regarding virus vector vaccines for organ transplant recipients that in very, very rare cases they might trick the immune system to produce antibodies directed against the donor, which could increase the risk of rejection. Maybe and hopefully this will not occur at all. Transplant recipients in Great Britain now receive the virus vector vaccine, and we should be able to rule out or rule in this theoretical concern within a few months. At our center, we would love to see organ transplant recipients being given priority for the RNA vaccine, mostly because they are shown to be most efficient. But to insist on that would produce a logistic problem in the municipalities that are responsible for vaccination of their population. The most important thing is to receive a vaccine. Therefore, we recommend to our patients at our center that are either a transplant recipient or waitlisted for transplantations to gently ask those in charge of their local vaccination program if it will be possible to get a RNA vaccine. If they are scheduled for a virus vector vaccine, they should take this offer to avoid that their vaccination is delayed. Take the vaccine, that is the take-home message. Since we do not know how well the vaccine will protect organ transplant recipients or other persons on immunosuppressive drugs, and since the vaccine protects against serious illness during COVID-19 and to a lesser extent protect against spread of the coronavirus, it is important to still follow infection control advice. Social isolation will lower your spirit, and I recommend those who feel lonely or overwhelmed by the amount of information on COVID-19 to familiarize themselves with the LNT website and their peer work. You might even find a friend. Thank you for watching this video.